exit in the very back. We've got some great speakers for you this afternoon. Our first one up is Dr. Azarbehi. She's going to talk about behavioral intervention in the DSM-5 and some recent research in that area. She is a professor of psychology at Tyndale University. She's also the director of clinical services at Kids Solutions here in Newmarket. We're very excited to have her, especially because she's done a lot of work with my son particularly. She's been a very, very heavy influence on our family. We've also got Chris Duggan from Carrie's Place. We've got Sonia Doherty going to be talking with us. She's a naturopathic doctor. Kathy Soul from York Region Early Intervention. And Angela Young is going to talk to us about some menu planning and recipe modifications. If I could get Dr. Azarbehi.
Otherwise, I might have a disconnect. So I'm very pleased to be here today, and I'm going to be speaking on skip forward a bit, 3 broad topics. I'm going to be talking about the DSM-5 and the diagnostic changes that are coming up. That's something I've been asked a lot about, and Rob said you might have some interest in. I'm going to be talking about IBI, or Early Intervention Services, and then we're going to have a Choose Your Own Adventure portion of the presentation, where I'm going to talk about recent research in autism, and I have 9 possible areas of recent research that I can talk about. So I'm going to have a Choose Your Own Adventure, poll the crowd. You guys can tell me what slides you want to hear about, and those are the ones that I will talk about. How many people have heard me speak before at a different event? Not too many. Okay, good. So the slides won't be some of the slides I reuse. So first, just quickly, Robin mentioned that I'm a professor at Tyndale University. I teach psychology, and I do research related to early intervention services and autism. I'm a clinical psychologist, and so my doctoral training research focused on how can we make early intervention services as effective as possible. And I continue to do this research as part of my work with Tyndale. I'm also the clinical director at Kids Solutions, which is a child and youth mental health center, and our physical building is right here in Newmarket, although we provide services all across the GTA York region. And we do social skills groups for preschool, school-age teenagers. We do assessments. I do assessments and diagnosis. We supervise a lot of IBI programs and provide one-on-one IBI services. Both at our center, in people's homes, in schools, daycares, that type of thing. We do behavioral consulting and planning, basically anything child and youth mental health. About 60% of my private practice is autism related. That's my research area, and it's definitely an area that I'm heavily involved in. But about 40% is just other general child and adolescent developmental concerns. So learning disabilities, depression, anxiety, typical things. At Tyndale, if you want to find out more about some of the research and work I'm doing at Tyndale, you can visit tyndale.ca/TRACE. TRACE stands for Tyndale Research in Autism and Community Education. And we offer a lot of free services through that program. So we offer parent workshops spread out throughout the year. We do ongoing research, and we offer a free March break camp every year for children with autism, a social skills camp. And then every August, we run 2 weeks of social skills camp, the last 2 weeks of August, where it's reverse integrated. So it's about 25 kids with autism and about 8 typical kids for each week of camp. And we focus on just having fun and doing normal day camp activities, but also specifically teaching social skills. So the summer camp, there is a fee involved, but the March break camp and all the parenting courses, there is not. Okay. So, one of the topics that Robin had asked me to speak about was the DSM. So how many people have heard of the DSM? Great, we've got an informed crowd. So the DSM stands for the Diagnostic and Statistical Manual. It's sort of often referred to as the Bible of psychology and psychiatry. So any diagnosis that is a mental health diagnosis must be made according to the criteria set out in the DSM. So if a physician or a psychiatrist or a psychologist is going to diagnose someone with anxiety, depression, autism, borderline personality disorder, anything like that, alcoholism, it all goes by the DSM criteria. So we're now on our 4th version of the DSM. Every 15 years or so, they come out with a new DSM. And each time they come up with a new DSM, they spent at least 5 years working on it, trying to see what more have we learned about psychological disorders since the last one that we can use to refine our criteria, to build on our understanding. Sometimes they add new disorders, other times they take disorders away, right? So for example, there used to be a disorder for females that was called, female hysteria, that was supposedly caused by your uterus swimming. And so the treatment was to remove your uterus and thus your female insanity would be gone. Medical understanding has moved beyond that. That diagnosis is no longer in the DSM, right? Other disorders have been added as we gain more understanding. So a new version of the DSM is coming out in 2013. And with it, there are some changes coming in how we diagnose autism. So currently, the current DSM, the DSM-4, identifies autism spectrum disorders as having 3 separate disorders. You can be diagnosed, someone can be diagnosed with autistic disorder, someone can be diagnosed with PDD-NOS, a pervasive developmental disorder not otherwise specified, or someone could be diagnosed with Asperger's disorder. So these are the 3 disorders in the current DSM. And currently, the way that we diagnose these disorders is based on 3 different diagnostic categories. So to diagnose someone, we look for qualitative impairments in social interactions. So the DSM lists numerous examples about how their social interactions might be impaired. We look for qualitative impairments in communication. And we look for repetitive and stereotyped patterns of behavior or obsessive interests. And those are the 3 areas of symptoms that we would use to diagnose if someone falls into one of these 3 categories. So the main change that is coming is that under the old system, we had these 3 separate diagnoses: autistic disorder, PDD-NOS, and Asperger's. Under the new DSM, there's just one diagnosis, which is going to be autism spectrum disorder, rather than 3 separate diagnoses. And the reason for this is because there's been a lot of concern by researchers and practitioners that under the current system of placing people either in autistic category, PDD category, or Asperger's category, it's often a parent could bring a child to one person and be told you have PDD and NOS. Go to another person, be told it's Asperger's. 5 years later, be told it's autism. The categories right now are often confused. They're not as clear about which category might somebody fall into. So the new approach is an attempt to say, on the whole, it's autism spectrum disorder, and then they will use sub-specifiers to describe a specific individual. So they will say the person has an autism spectrum disorder, and then there will be a number of specifiers that you can use to describe what type of disorder. So the new criteria are designed to be more thorough and strict. So for example, there's going to be more possible symptom examples listed under each category. So it will be clearer for people to be able to understand what might count as a qualitative impairment in social interaction, what might count as a qualitative impairment in social communication. It's also being reorganized a bit, so they're combining social/communication deficits into one group. That's more just a paper thing. And they're also removing some of the age restrictions. So it used to be that in order to have Asperger's disorder, one of the things, you could have no language developmental delays. And it used to be that to be diagnosed, there were certain symptoms that you had to have record of prior to the age of 7. And this made diagnosing older teenagers or adults difficult because sometimes people might not have noticed something prior to the age of 7. And so therefore, they might not be able to have a diagnosis simply because they don't have a record or information about what's happening prior to the age of 7. So the new DSM just looks at current functioning. How is an individual currently functioning? And so overall, someone would be diagnosed with ASD, autism spectrum disorder, and then there would be a number of descriptor terms that could be used to describe that individual. So it's hoped that it will be more of a personalized diagnosis. So there are 3 different areas that different levels can be assigned to. So first, amount of support needed. So when someone's diagnosed with ASD, there can be a descriptor code about how much support do they need, level 1, level 2, or level 3. Because, you know, right, like currently, there are some people that were diagnosed with Asperger's that actually need more daily support than someone diagnosed with PDD or NOS, right? These categories are somewhat arbitrary. You can also put a code on the severity of challenges with social communication and a code on the invasiveness of the restricted interests and repetitive behaviors. And then there will also be over 20 other descriptors that can be used to help describe a specific individual. So the diagnosis will simply be ASD, that's the diagnosis, but then you can use different descriptors to further try to describe an individual. And Asperger's, it should be noted, will remain as a possible descriptor term. So what are some benefits and some concerns? So some of the benefits that are hoped to occur are clearer diagnostic criteria. They're going to expand the descriptors, expand the explanations. Less confusion over categories. I see this a lot. I'll have a parent come to me and they'll say, my pediatrician or my physician said it was PDD NOS. Often physicians they like to use the PDD NOS category for some reason, whereas psychologists more often use the autistic category. And so they'll say, well, my pediatrician says it's PDD NOS, but the psychologist at Markville Hospital said it was autistic disorder. Which is it? And there isn't really one or the other. It's just an autism spectrum disorder. So hopefully this will help lessen some of that confusion. It'll be easier to diagnose older individuals, and the hope of the committee is that it will allow wider access to services, especially with insurance. So in the United States, in 30 of the states, I believe, they have won lawsuits that have now making medical insurance companies have to pay for autism intervention services. But the insurance companies are saying, well, we'll pay for autism intervention services, but PDD, NOS, and Asperger's don't count, right? Which is causing a lot of families not to be able to get insurance benefits because insurance is saying, oh, it's not autistic disorder, it's PDD, NOS, or it's Asperger's. So now that everybody will be autism spectrum disorder, the hope of the committee is that will clarify it, that no, everyone should get access to these services. So that is the hope. What are some of the concerns? Well, amongst the ASPE community, this is often what people with Asperger's, when they self-identify, quite a common self-identifier is, I'm an ASPE individual. This can be an important part of their self-identity. And so there's quite a lot of concern amongst people with Asperger's that if the criteria change and their diagnosis changes, that changes something about their own identity. And so there's a lot of concern about that. This is why Asperger's has been kept as a descriptor term. There's some concern about that. You can read up that. There's also some concern about how the education systems might react and how insurance companies might react. So the hope is that it will open it up, right? But they can always try to find loopholes and start saying, well, only someone with a level 1 and a level 2 and a level 3, and then, but you don't actually need to assign a level for a diagnosis, so hopefully we can get around that. So if you want to find out more information, I got my information. I was at the INFRAR conference, the International Meeting for Autism Researchers. It's an annual conference, multidisciplinary, and the chair of the DSM committee that's revising the autism criteria spoke for an hour long to the professionals in the conference and went over all of this. There's not an hour-long video because you might fall asleep, but there's a 10-minute long video from her available on this link if you'd like to hear right from her mouth some of this information. And you can also visit the official DSM website and read some more information about what these changes that are coming. So now I want to talk briefly about IBI. So what is IBI? Often people say IBI, ABA, there's a lot of confusion. What does this mean? So IBI stands for Intensive Behavioral Interventions, IBI. IBI, Intensive Behavioral Intervention, is based on the principles of ABA, Applied Behavior Analysis. So ABA, or Applied Behavioral Analysis, takes the principles of behavioral psychology and uses those principles to best teach people. So if we look back, one of the most famous behavioral researchers is Skinner. Has anyone heard of Skinner? his pigeons, yeah. Some great videos online with Skinner pigeons. And so Skinner, back in the 70s, was really interested in how can we help people to learn more efficiently, right? And his interest started off with typical kids. He was really interested in how can we make learning more efficient for typical kids. And one thing he found out, for example, is that if you're trying to teach math, rather than having kids do 3 pages of a math worksheet, hand it in, the teacher puts X's and check marks, get it back, have a huge delay between the answer and when they get feedback on the answer. If you give immediate feedback, it speeds up learning by a factor of 10, right? So he identified immediate feedback is important. Other behavioral researchers continue to look at how can we maximize human learning? How can we design learning to make it as effective as possible? So ABA is applied behavior analysis. It tries to apply what researchers have learned about human learning and behavior in an applied setting to solve problems. And IBI, intensive behavioral intervention, is an intensive form of that. So often kids with IBI programs get 20 to 40 hours a week of one-to-one teaching and instruction using the principles of ABA. So when we talk about early intervention programs, there are a lot of different approaches to early intervention. There's IBI, which is kind of the founder of IBI was Lovas. That's the guy on the far in the black and white. I was really lucky as part of my education, I did my undergrad at UBC, then I spent a year at UCLA and I got to work with Lovas and train in his intervention clinic and learn some skills. So Lovas was kind of the pioneer of working with kids with autism. So prior to Lovas, it was thought that kids with autism were unteachable. They were primarily institutionalized in the 50s and the 60s. Lovas, in his first study, said, I don't believe that these kids are unteachable. I think that they might need more intensive teaching to teach them something, but I bet I can use what we've learned from behavioral psychology about how humans learn. I bet I can use that behavioral knowledge to teach these kids with autism. So he took 5 kids out of an institution, brought them to UCLA, and spent 2 years having graduate students work intensely with these kids to try to teach them. And they made incredible gains. Kids that had never spoken before, when they were 12 years old and got the intensive intervention, started speaking, started reading, started interacting. They made incredible gains. And so he was the first person, Lovas, to demonstrate that there's potential, really. That no, you shouldn't just institutionalize these kids and think you can't teach them anything. That's ridiculous. These kids have potential. They might need more intensive learning opportunities, but they can learn. So Lovas is sort of the founder of that. And then he continued to build on that, and so did other people. And what they found was the best time for this early intervention was when the kids were young. I'm going to talk about that in a minute. There's a lot of other interventions as well. There's RDI. How many people have heard of RDI? So it's quite popular in Ontario right now. And it tries to focus on relationship development. There's the Greenspan floor time method. How many people have heard of Greenspan floor time method? Yeah. They're doing research right now on the Greenspan floor time method at York University, which is, I think, quite interesting. There's other methods, like there's a company in the States that they'll charge you $8,000 to send you special purple sunglasses that will filter the visual information and help cure your child, and we're probably all pretty skeptical about that. There's the TEACH program, there's swimming with dolphins. Might be fun, might be a good reinforcer for learning, probably not a treatment method in itself. So, when we talk about early intervention services, we need to understand why is early intervention important. So at the beginning, when you guys were all coming in, there was a video up on the screen. And the researcher that was talking about neurological research into autism. They're trying to understand at a very neuronal level, cellular level, what is happening inside the brains of people with autism. And that video can be accessed online. Is that correct, Robin? Yeah. And Robin can tell you guys more after the break about how you can find it. I think it's a fascinating video. But when we started to look at the brains of individuals with autism, what we have found is that in the first 5 or 6 years of their life, the process of plasticity and myelinization is not developing as it should. So what is plasticity and myelinization? Let me put it this way. We're all born with about 30 trillion brain cells. 30 trillion brain cells. In the first 5 years of life, that number drastically reduces. And that's a good thing, because what your brain is doing is it is taking the brain cells that you're using and the brain cells that are communicating with each other, and then it's keeping those. And it's reabsorbing the brain cells that you're not using, and using those reabsorbed brain cells to myelinate or to create super connections between the brain cells you are using. So in the first 5 or 6 years of life, your brain is figuring out how does it need to communicate with itself? What brain cells does it need to use to function, to understand the world, to interact with people? And as it's starting to figure out how does it share information appropriately, how does it communicate within itself, it is starting to create these myelinated sheaths. And myelin sheaths, it's like the difference between brain cells connecting using dial-up versus brain cells connecting using broadband, right? Broadband is way faster. So brain cells that aren't myelinated can still communicate with each other, but it's a slower, more difficult process. Whereas brain cells that are myelinated, super fast. So in the first 5 or 6 years of life, the brain is going through this immensely complex process of deciding which are the brain cells that are important, which are the brain cells that are used, which are the connections that are most important, and strengthening those connections. So what we know about individuals with autism is that their brain cells are not undergoing that same process to the same extent. There's a problem with the myelinization process. The connections that should be forming are not forming. So we can see this in action with MRI machines. So how many people watch House? Anyone? House, cranky British doctor on TV? Or is he's American in the show? Right, so if you've watched House, you've seen MRI machines in action, right? They put you in a big tube, and a magnet spins around, and a picture of your brain pops up. And fMRIs allow researchers to actually have ongoing video-type images of your brain so that they can see what's happening in your brain. They can see how your brain's passing information around. So if I put a typical individual into an MRI machine, and I showed them a picture of a dog, immediately the occipital lobe, the back part of the brain that processes visual information, would light up. Because they're getting visual information, they're seeing a dog. Almost instantaneously, however, other parts of the brain would begin to light up because the occipital lobe would share that visual information with the frontal lobe, where you would be thinking about memories of dogs. The emotional centers would light up because you would be, if you like dogs, feeling happy. Oh, it's a cute puppy. If you're scared of dogs, feeling fearful. The temporal lobe, some of the auditory sections of your brain would light up because you're not hearing anything, but you'd be remembering what the sound of a dog is. So immediately, all this information would be shared with different parts of your brain. When we put individuals with autism into a scanner machine and we show them something like a picture of a dog, the occipital lobe lights up right away, but doesn't share the information as well with the rest of the brain. The rest of the brain doesn't light up as well. And so we are starting to understand that it's in the early years that these connections are happening. So if we want to intervene to help these individuals make these connections, we need to do so when they're young. Now, our brain continues to be a plastic organ. We continue to be able to develop myelinization as we're older. Does anybody here play the violin? No. Good. If all of you started playing the violin, if I did brain scans on all of you now, and then I made you take violin lessons and you dutifully practiced, and a year from now I did other brain scans, I would see that you would have developed new connections in your brain related to playing the violin. So you can, even as an adult, absolutely the whole phrase, old dogs can't learn new tricks, is false. Your brain can make new pathways and learn new things, but it's more difficult. And the really sort of intense time of these brain developments is in the first few years, which is why early intervention is so important. So then that brings us back to, if we know now that early intervention is really important because we want to force these connections to happen, we need to ask ourselves, what are the different types of early intervention that is out there? So there are a lot of different types of early intervention out there. I don't have time right now to talk about the the research support for all of these different, or lack of support in some cases, for all these different interventions. But I've put in the PowerPoint slides, and I will send around a sign-up sheet if you would like to have a copy of the slides. Links so that you can click on them, and these links give you summaries of all the research related to these different types of early intervention. So you can click on the link for IBI. And IBI has the most research supporting it. So it's been intensively researched for about 30 years. It has a lot of research supporting its effectiveness. You can look at RDI. RDI has 2 research studies. So it's more limited, it's a newer approach. Greenspan floor time method. I'm really excited because York University is right now doing a giant study looking at the effectiveness of Greenspan floor time method. And the reason I'm pleased is because prior to this study being done, there was only 3 studies, and all of them were done by Greenspan himself, and they were all published in a journal that he himself created to publish his articles in, which makes me rather suspicious. Because typically, if you're a researcher and you want to publish research, you do so in a peer-reviewed journal. You send your research in to a journal that has a panel of experts in the field that examine your research to see if it's legit, and if it is, they will publish it. So, but Greenspan floor time method is quite popular, especially Eastern Seaboard USA. So it will be nice to have some research out of York University, some standardized measures to see is it effective. If it is effective, great, we have one more tool we can use, right? I'll be thrilled to hear it. If they show it's not effective, I'll also be glad to hear that, because then not only can I say to parents, you know, it really doesn't have any proof, I can say actually the only study that did do it found it's not effective, so don't waste your time. So either way, if it's effective, wonderful, right? If it's not effective, good to know too. Okay, TEACH. How many people have heard of the TEACH program? So TEACH is based on the principles of ABA. So when we talk about IBI, TEACH, or PRT, Pivotal Response Training, who's talking about Pivotal Response Training today? Are they here yet?
Kathy Soul, she's not here yet.
Not here, okay. So Pivotal Response Training is also based on the principles of ABA. So IBI, TEACH, and Pivotal Response Training they all use the principles of behavioral learning. They just do so in slightly different ways. But as a group, they are the most research-supported interventions. So TEACH has some good research showing that it's very effective for teaching specific skills. So TEACH, especially working with older kids and teenagers. So if you want to teach someone job skills, you want to teach them how to work as a stock boy in a grocery store, TEACH systems are a great way to do that. You want to teach someone independent living skills, TEACH works well. You want to teach them specifically how to do math, TEACH works well. What TEACH doesn't have is any research showing that overall, if you take a kid, put them in a TEACH program for 3 years, and then look at them at the end, that overall they will have made an across the spectrum improvement in skills. So it's good for teaching specific skills, but they haven't shown that it's an overall intervention. Whereas IBI has done that. So IBI has been shown to be effective for teaching specific skills, but it's also done the research, which has been replicated many times, that shows if you take a young child, 2 or 3, with autism, and you put them in an intensive IBI program, 20 to 30 hours a week for 2 to 3 years, by the end of that program, they will have most likely made significant gains. About 40% will have moved off the autism spectrum. About 40% will remain on the autism spectrum, but will be able to be in typical classrooms with extra supports. About 20% really don't make significant gains. And there's not an understanding as to why that 20% does not work, but about 20% really don't. So IBI has been proven to be effective for teaching specific things, but also to be effective for improving the overall developmental trajectory of a child. So what IBI does is, if your child is going to start an IBI program, the first thing people will do is do an assessment to identify what specific skills does your child need to learn. They'll often do an ABLES. So this is an ABLES, and the ABLES looks at 24 different areas of development. So it looks at receptive language, what do they understand? Expressive language, what can they say? Fine motor skills, gross motor skills, reading, spelling, math, social skills, group instruction skills, dressing skills, eating skills, communication skills, conversation skills, Basically, it's an attempt by a researcher named Dr. James Parrington to categorize in a visual format, by the end of grade 1, what skills should a typical child have in order to continue and go on and succeed. So it's 4 pages long. This just shows the first page. So it's 4 pages of skills, hundreds of different skills that are key for children to know by the end of grade 1 for them to continue on. So when you do an assessment, so this child's first assessment was done in, whoops, I better stop walking, in yellow. Okay. So the first assessment was yellow. They tested all of these individual skills, and any skill that the child knew, they colored in yellow, right? So then they could visually see where the child was. Then, based on what they didn't know, they picked what to teach, right? Then every 6 months you redo the ables, and you choose a new color. So the second time they did the ables, it was red. So they added in, and they could visually see the progress that the child was made. And then the third time they did the ables, they used blue. So the goal of an IBI program would to have the entire thing colored in by the time the child finishes the program, hopefully by the end of grade 1, right? We do also use the ables for older kids as well, though. So often kids might not start IBI until they're maybe 10 years old, right? There's a 4-year wait list in York Region for IBI services. So your child might be starting IBI when they're 10. Right? But if they're getting IBI funding, it's probably because they are still struggling with some of these basic communication, social, learning skills. So even though numerically, age-wise, they're 10, their development is probably still delayed in many of these areas. So we will still do the ables to try to figure out what are the key, most important skills for us to look at. And every box is an individual little skill. So IBI, one of the key teaching methods used by IBI, so like I said, it's based on behavioral intervention. One of the key things used is discrete trial teaching, or an SD loop. So that's basically the idea that what you need to do to most efficiently teach people information is first make a request of them, like touch red, then wait for them to respond, and then give immediate feedback. And if you need to help them, you give the response, immediately prompt, and then give the feedback. So we don't have time to go into the details, but this is one of the key skills of IBI. So if you're looking to obtain IBI services, there are a few different ways that you can do so. So first of all, there are some government-funded IBI programs. TPass, if you live in the GTA, or Canard, if you live in York Region, are government-funded IBI programs. So first of all, your child needs to go, you have to phone them, and you have to be deemed as having a child that is severe enough to warrant IBI. Then you go on a wait list. TPass is definitely a better wait list to be on. It's about 18 months to 2 years wait. Canard is about a 4-year wait. It's a long wait for funding in York Region, unfortunately. Which is why a lot of parents of young children, knowing that those early years are so important, look to other methods. So there is private funding. So if parents are able, they can pay out of pocket to have IBI services. It's expensive, but they can do so. Or they can try to use some insurance benefits to do so. And there are some other funding sources. So if your household income is below $80,000, then you can qualify for PC Children's Charity, which pretty much guaranteed you'll get $5,000 of funding from that. And Laura Ashley funding is another funding source, but it has a lower household income. Yes?
It's Jennifer Ashley.
Jennifer Ashley, thank you. Jennifer Ashley funding. I think Laura Ashley, are they clothing? Yeah. Yeah, okay. So no, Jennifer Ashley, thank you. So if you get the government funding, TPass, once you come on the list, pays for 25 hours a week of one-to-one therapy, one-to-one IBI therapy. Canard pays for 20 hours a week. The government pays $39 an hour for those services. So when you come off the wait list, you can either go to a government-run IBI program, where you drop your kid off at a government center, or you can go with a private agency, and you can pay the $39 an hour to a private agency. You need to be careful when you go to the private agency that you check that there aren't hidden costs, because often the $39 an hour will cover the one-to-one worker, but then they'll charge you extra for the senior therapist that supervises, and then they'll make you pay extra for the psychologist that's required to spend time every month with your child. So you need to, I've had some parents be quite burned badly by unexpected fees, so make sure that you find out all the different things. Was there a question in the back? Nope, we moved on. Okay. Yep, there is a question. Yes.
Right, in terms of the service delivery difference between TPass and Canard, it's my understanding that for TPass the waitlist is shorter, but they only provide, is it 2 or 3 years of IBI and then they're finished, whereas Canard 4 years, but they'll keep seeing them for a longer period of time?
So both of them are supposed to follow the same criteria, which is that as long as the child is making significant progress, the funding continues. TPass is much stricter in what they consider significant progress. So TPass kids, because like I've said, with IBI, about 40% will be fast responders, optimal responders. Kids where they start IBI and they take off. They're really doing well. About 40% are kids that will respond, but not as quickly. So they're having benefits, but they're not as quickly. And about 20%, it just does not work with those kids. So both TPass and Canard are supposed to have policies that state that at the end of a year, if you're in the 20% that's not making progress, your funding ends ended because it's not working for your kid. If you're in the 40% that's making some progress but not great progress, it will be reviewed and maybe you continue, maybe you wouldn't. If you're in the 40% that's doing amazingly well, funding will continue. Practically speaking, how it, unofficially, but how it does work from what I've seen, is that TPass is much stricter about that. So TPass, if you have a kid that's taking off and doing well, you can keep 3 or 4 years of funding with TPass. But they're much quicker to say, you know what, it's not working, it's time to transition out. Whereas Canard seems to have everybody, no matter what, can have the 3 to 4 years of funding. So the trade-off is that TPass, because they're being stricter, the wait list, they've managed to really bring the wait list down, right? It's a difficult call. One other question? Yes?
Yes, you also mentioned that you use insurance.
Yes. So if you have extended medical coverage, like that helps pay for prescription medication, then you likely also have coverage for psychology and speech and language pathology and occupational therapy. So not all private agencies, but some private agencies, if they have a psychologist on staff or a speech and language pathologist on staff, you can use those benefits to pay for the IBI. So with Kid Solutions, for example, because I'm on staff at Kid Solutions, parents can use their psychology benefits to help pay for IBI. And most people's psychology benefits are either $500 per person per year or $1,000 per person per year. And because IBI services involves one-to-one with the kid, but it also involves parent meetings, parent support, we can bill under the kids' benefits and the mothers and the fathers. Same with speech. So with Kid Solutions, for example, we have a speech path that consults on all of our programs. So the speech path will consult and will give us speech goals to work on in IBI. And therefore, we can use some of the speech pathology insurance to cover the IBI because our IBI therapists are working. Not many agencies are able to do that though, so you would need to make sure that you do the research and find it ahead of time. Because most agencies don't have a psychologist on staff, and the same with the speech and the OT. Robin?
I was just going to add to that, but it's not just IBI, but it's $2,000 for an assessment. You can get a nice chunk of that covered under your insurance too. The assessment can be covered as well as.
Absolutely. So the same as social skills groups at our agency because I'm a psychologist. So you can use psychology benefits to pay for social skills groups, to pay for parent training, to pay for an assessment or a diagnostic report. Most agencies, when they offer social skills groups, they don't have a psychologist supervising them. They have a master's level therapist, and so therefore you couldn't use insurance benefits to pay for those groups, right? Because they don't have a psychologist supervising them. Funding is complicated. Yes?
I'm aware that special services at home can help support social skills. They won't do any other therapy, but they do support social skills programs.
Yes, so I have had some special services at home funding be used for social skills groups. It is, however, seems to be depending on who the caseworker is. So I've had some parents that have had no problem using special services and home funding to pay for social skills groups, and other parents be told by their worker, no, that's a therapy, you can't use it. So, but you could try. Yes.
Do you have a wait list
No.
for yours, or is there criteria of having to live in the area?
Nope. But no, so Kid Solutions, we work with TPass funded clients, we work with Canard funded clients, we work with charity funded clients, and we work with privately funded clients. We ourselves are not directly government funded because OHIP doesn't cover psychology, right? So if you don't have funding from another source, we still offer services, but then it's pay out of pocket. And our rate for IBI is $39 an hour flat, and it includes everything. So I'm rather proud of that. We worked really hard to make that possible. And if you do your research and look around, you'll find that's very, very rare. But our $39 an hour includes the one-to-one with the kid, the 8 hours a month of senior therapy, the 2 hours a month of psychology, speech and language consult, and OT consult. There's absolutely no extra fees, which I've worked really hard to be able to offer that. Okay.
Amanda?
Yes. Yes.
I just wanted to ask, we've been on the wait list with Canard forever.
Yes.
Our son has another year and a half.
Right.
And if he went to TPass, how do we do that? And
So it's where you live. You have to live in the GTA.
You do, so Canard is that's North Region.
That's your region.
Okay.
If you move between regions, then they do honor where you were on the previous wait list. So that's the good news. If you move, you don't have to start again at the lowest. But it's just wherever you file your property taxes.
So GTA, how far does TPass consider GTA?
If you pay York Region property taxes, then you're in York Region. If you pay Toronto property taxes, you're in Toronto. Yeah. Yes.
You were talking earlier with regards to how strict the funding is. Children didn't fall within that 20%.
Right.
What happens then?
The 20% that don't make progress. So she's asking for a little more information about what happens for those 20% that don't make progress with IBI. So they remain severely impaired. So those are the kids that, despite getting intensive therapy, will likely remain nonverbal, remain having incredible difficulties learning. They're likely to need one-on-one support their whole life. They're just going to be the ones that remain in the most severe.
Ones that were formerly institutionalized.
Yes. Yeah. What's interesting, though, is that all the research, they've done a lot of research to try to predict where kids are going to fall, right? So can you predict before therapy starts which kids are going to be in the best 40% optimal, which are going to be in the middle, and which are going to be the lower 20? And what's interesting is that you really can't predict based on characteristics before they start therapy. So kids that are verbal before they start versus kids that are nonverbal, you actually can't predict end outcome. The best predictor of end outcome is to look at how quickly they're making progress in the first 3 months. So, so we wouldn't want to start triaging and saying, oh, well, this kid seems more severe, so he's definitely, obviously going to be in that bottom 20% that doesn't work, right? Whereas this kid seems less severe, so they're more likely to be in the top. It actually is not very well predicted that way. But the best predictor is get them in therapy, look at the first 3 months, how quickly are they learning? That's actually the best predictor of outcome. Yes?
What if the therapist did not do a good job in that lower 20 and they move to another therapist and show improvement?
It could certainly happen. So he's saying, what if the reason why someone's not showing improvement is because they have a terrible therapy team? So maybe they seem to be in that bottom 20%, but it's because they have bad IBI. It can happen. I'm on the committee with the TPass committee right now that's looking to try to establish more standards for IBI providers and more information for parents to be able to understand who's a good agency and who's not. Because there's no Like to be a psychologist, I had to, you know, I had to do like 12 years of postgrad training, but I also had to sit board and licensing exams, right? And I belong to the College of Psychologists, and so if I do a bad job, someone can explain to my college, and I can be called up in front of them, and I can be disciplined, I can lose my license. I'm accountable as a psychologist, right? Same with speech and language pathologists, same with occupational therapists. They have a license that they can lose, so they're regulated. Unfortunately, IBI providers, anybody can start an IBI center. It's not a protected term. It's not a protected phrase, right? So somebody that's completely unqualified and that has numerous complaints against them, other than the Better Business Bureau, there's really no one you can even complain to. They don't have a license to lose. Which is why when you're looking around for an IBI provider, it's really important for parents to understand what kind of questions they should be asking and how they should be looking to determine who's qualified or not. Because there are some terrible providers out there. There's some great providers out there, and there's some terrible providers out there. And it's waited for years to get funding, and you finally have it. It would be tragic to have that funding go to a really terrible provider. So TPass is currently, we have a working committee, and they're working on trying to establish for parents a document that would outline what are the key questions you should ask, what are the key things that you should look for that are signs that this is a good provider. Yes?
But if you have private therapy already established,
Yeah.
and your child's name gets picked up on the list, you use that private therapy. Do you not?
You can stay with the same private therapy, or you can move. So if you have been paying out of pocket for private IBI while your kid's on the list, and then you get funding, you can either switch your kid to the government center run one, stay where you are, or switch your kid to a different agency. Now the one thing is, if you do stay where you are, you can only do so if you can find a clinician in charge, a psychologist that's willing to supervise your child's program. So Canard and TPass do not approve agencies. They don't regulate agencies. So there's no such thing. If anyone says to you, oh, our agency's Canard or TPass approved, it's a lie. There's no such thing as a Canard approved agency. All Canard and TPass do is they approve the clinicians in charge, the psychologists, the people that have a license and are actually responsible, right? So, so for myself, for example, Kid Solutions, which is my agency, I supervise IBI programs through Kid Solutions, but I'm also employed by numerous other agencies to supervise their kids' funded programs. Because most agencies, so I think we're the only agency, every other agency that I know of, none of them have a psychologist on staff. So which is fine if they're doing privately funded therapy, they don't need one. But when they get government funded therapy, they have to be, all government funded programs have to be supervised by a clinical psychologist. So if you have your kid in a private program that does not have a psychologist supervising it, and then you get funding, you then have to find a psychologist that's willing to supervise your kid's program. Some agencies, it's easy to do that. So for example, puzzle pieces. It's easy for them to find a psychologist that's willing to work with them, they do good work, right? Other agencies, if your agency says, oh, it's going to be really hard for us to find a clinical supervisor, it's probably not the best sign, because that's probably because most psychologists aren't willing to sign off on them. So sometimes parents do have to change agencies when they get funding because a psychologist is not willing to work with their agency. Does that make sense? It's a messy world.
Can I ask one more question?
Yeah.
I have many parents who is asking me when they are on DFO, where can they find a list of psychologists that they can contact?
Yeah, good question. And Canard and TPass won't give you one.
That's right.
Because they don't want to be liable for it. So it's through word of mouth. They will sometimes unofficially, I have been told by parents that they've unofficially told Dr. Azarbehi. But there is no list, which is ridiculous. So it's very much through word of mouth.
Do you do DFO?
Yes, I supervise DFO clients.
Thank you.
Yeah. I'm not willing to just supervise anyone because it has to be with a good agency. So I myself, I've only been in Ontario for 3 years, and when I first came, I had more faith in agencies than I should have. So I will not name names, but there were a couple of agencies that I supervised programs for that I had to terminate my services within 6 months because they were terrible. It was awful services that were being offered. So I won't just supervise anybody. I mean, you know, there has to be.
So they don't have an association of clinical psychologists where you can find a list or something?
No, they don't have one. Yeah. Yes?
Is there a wait list for the IDI Active Solutions?
So there's not a wait list for IBI at Kid Solutions. It does cost for non-funded clients $39 an hour. We also do have a pro bono program, but of course our pro bono program wait list is about 2 to 3 years. So just because there's no way we could do everybody. Yes?
So I can just ask, because most places will require you to do a minimum of so many hours a week. Do you have that in place, and what is that number for you guys?
So we don't have a firm minimum number of hours a week at Kid Solutions. We typically recommend about 10 hours a week, just because if you want to be working on a number of goals and you want to make quick progress, 2 hours a week is not likely to develop that momentum, right? So I want to, if I'm offering your child an IBI program, I want to offer a program that is going to gain momentum, that's going to get them moving, where you're going to see progress. And 2 hours a week is very unlikely to have that happen. If you want 2 hours a week to work on a specific thing, then that might work great. So let's say that you come and you say, my kid's doing pretty well, you know, in school, but they really are having specific difficulty with this, right? Then maybe having them come for 2 hours a week for a semester to work on that specific thing, we could see great progress. But if you want IBI, where we're addressing 10 or 15 different learning goals all the time, every session, then usually it's, you know, 8 to 12-ish. But we work with families and come up with the solution that works for them, right? So if you could only afford 4 hours a week, it's not that we won't work with you, but we'll say, okay, but we do need to explain that that means that we're not going to be targeting 15 to 20 things. We're going to have to be narrowed in. We're going to have to target maybe 2 or 3 goals at a time. And we would just make it clear that, that we would do that in a way that still is efficacious, if that makes sense. Yes?
Is there any thought of the government stepping in with mandating how to regulate this industry? Because as the numbers tend to rise, people are seeing this as a cash grab, and everybody's getting into the business. And you know, they're preying on people's vulnerabilities.
Absolutely, yeah.
And
from what I know, there is no government steps to do that.
because they mandate other colleges.
Exactly, so they do mandate colleges. So I mean, one thing you can do, if there's a psychologist supervising the programs, then you do know that ultimately the buck does stop with someone, right? So in our agency, I'm not necessarily the one leading every social skills group, but I'm the one clinically responsible for the social skills group, right? So if it's a terrible service, if it's not providing what it says, you can complain to the college. I could potentially lose my license over that. So I am, you know, putting my license on the line. Speech and language pathologists also have licenses to lose. So I know some really good speech and language pathology groups that are being run. Another good credential to look at is for the BCAB, the BACB, Behavior and
BCBA.
Thank you. Oh my goodness, I always get BCBA, Behavior Certification Board of Analysis, Behavioral Analysis. So people with a BCBA have a master's level one, have completed numerous master's level courses, have a master's degree, and have written board exams, have done 2,000 hours of supervised experience. They have a very high standard. So another good thing to look for, very good thing to look for if you're looking for a service provider, if it's not a psychologist or a speech path or an OT, do they have their BCBA? It's not a license that they can lose, but it is a qualification that shows that they've done significant training, significant practicum placements, and that they've passed board exams. So it's a very good thing to look for. Okay, so we have 5 minutes. So in the Choose Your Own Adventure, I think we'll have one adventure maybe that we can get. I often speak at various events. So if you're interested in some of these, I usually speak once a year for community living. For Carrie's Place, I do workshops. So and Robin usually posts when I'm doing different workshops, different places. So if you're disappointed that you didn't get to hear more about recent recent research. You can probably catch me somewhere else where this will be our only topic, and you can have a chance to hear more. And Robin usually posts when I'm speaking. But so for today, we could talk about genetic research, video self-modeling, GPS research, age and diagnosis research, theory of mind research, social skills videos, anxiety, or immunizations. I'm hearing a lot of anxiety. Good choice, because we do know that people on the autism spectrum have much higher rates of anxiety, right? Especially high-functioning kids and kids with Asperger's. Kid Solutions, we run anxiety groups for kids on the spectrum and off the spectrum, and we also offer one-on-one therapy. So let's just flip here.
You know, some people say autism is anxiety. I've heard that expression.
Most of the kids.
Yes.
Probably.
So, I want to talk, where am I? Practically then, what is anxiety? So anxiety, some level would say anxiety is good for us, right? Anxiety is a normal reaction to a stressor. It helps us deal with a demanding situation. In some situations, anxiety can be a good thing. It's our fight or flight response, right? So if someone jumps out at us with a knife at night and our adrenaline starts to go, that's a good thing because we either need to fight them off or run away. And so it's really good that the adrenaline's pumping, our heart starts beating faster, our stomach stops using blood and puts all that blood to our muscles so that we can run or hit harder, right? Our eyes dilate, we're hyper alert. This is a good thing if it's in an appropriate situation. When anxiety becomes a problem is when that fight or flight response, that nervousness, is applied to situations where it's not adaptive, right? Or is experienced all the time. So I want to talk really practically then about how can we support kids with anxiety. So with Kid Solutions, I usually recommend 3 different things. There are some really good relaxation tools that you can teach your kids to use at home or at school. And there's some professional services. So some of the best relaxation tools for home and for school, one of the great things to teach kids is diaphragmatic breathing. So diaphragmatic breathing, progressive muscle relaxation, visualization, and mindfulness are 3 different ways that we can help tell our panicking brain to chill out. So when we're anxious, our brain is sending stress signals. Our brain is releasing stress hormones. It's releasing adrenaline, norepinephrine. Our brain is biologically freaking out, right? What we need to do to reduce stress is to somehow send signals to our brain that say, stop freaking out. Stop sending the stress hormones. Shut down the norepinephrine. Shut down the adrenaline. Bring down the overall level of arousal. And one way that we can do that is by physically sending signals to our brain that say calm down. One of the easiest ways to do this is with diaphragmatic breathing. There's a really good app called Breathe to Relax. All one word, Breathe to Relax, which is put out by the National Institute of Health in the US, but it's designed to help people learn how to do diaphragmatic breathing. But basically, diaphragmatic breathing is slowly breathing in while expanding your stomach, holding it for a couple seconds, and then slowly breathing out, taking longer to breathe out than it took you to breathe in. If you do that repeatedly, that sends signals to your brain to calm down. Because it's impossible for you to do calm diaphragmatic breathing, for your brain to process the fact that you're doing calm diaphragmatic breathing and to be sending stress signals at the same time. The two just don't commute. So diaphragmatic breathing can help shut down those signals. And little kids can learn diaphragmatic breathing. It's very easy. Breathe to Relax is a good app. If you Google diaphragmatic breathing, tons of different things will come up. Progressive muscle relaxation is when you tighten and release various muscles. And it also is another way that you can send a physical signal to your brain to relax, because your brain is telling your muscles to tense and be ready to fight or flight. When you tense and release your muscles, you're fighting that brain signal. You're telling your brain, no, I can relax. There's some great progressive muscle relaxation DVDs, Parent Books I saw is sponsoring today. If you go to Parent Books, they're a great store, downtown by U of T, you can go online. They have some excellent CDs for preschool kids, school-age kids, teenagers, that walk them through progressive relaxation. For kids, it's often animal animal imagery that they'll use, right? So tighten up your face like you're a such and such, or stretch like a cat and do this and do that. Visualization is trying to distract your brain from the panicking thoughts that you're having. So anxiety tends to cause anxious thoughts. And anxious thoughts are often thoughts that we have trouble shutting down, right? We want to stop worrying about something, but the more we want to stop worrying about something, the more we think about that thing, right? And it becomes like, don't think of a blue elephant. You're all thinking of a blue elephant. So what can we do to kind of redirect our brain? Visualization, which can be anything. It can be visualize a calming beach, or visualize a special place. These same CDs that I talked about have visualization exercises on them. If you can redirect your brain to think about something non-anxious, it can stop those anxious thoughts. So these are some really great practical skills. Terry Orlick's CDs are excellent. Terry Orlick. On them, every CD basically has diaphragmatic breathing, has progressive muscle relaxation, has visualization, all on the CD. And you can practice the CD just in your living room after dinner with your kid. Once they get good at it, you can put it in the car, and if you're driving to something that's going to make them anxious, you can do it in the car. I really like his CDs. And there's a book called Taming Your Dragons by Belknap that also has really great exercises for like 5 to 12-year-olds on visualization, meditation, that type of thing. So those are really good. There's also some good workbooks out there that have been designed by psychologists to help kids learn some of the stress and coping things. So there's the Relaxation and Stress Reduction Workshop workbook for kids by Shapiro. There's the I Bet I Won't Fret workbook by Sizemore. There's the Anxiety workbook for teens. Parent Books has all of these. These are good resources. Often it's good to pair these resources with professional intervention services. So you can get these books and try at home to work through some of these with your kids. You can do that. If you can, though, it's often good to pair some professional intervention services. So I see kids one-on-one for cognitive behavioral therapy, or for anxiety or stress therapy, or some of the master's level therapists that I supervise do so, where we work with kids for an hour a week for usually 8 to 10 weeks to help them learn some of these skills. And so we practice each week a specific skill. We talk about how could you apply it. We send them home with their homework each week about what to practice. We let mom and dad know. We work together. So I think that is where we will stop for today. Thank you for your time.